thank you all for being here. I'm going to officially call this meeting to order. It is 6:41 p.m. And I believe the minutes from our last meeting went out. This is so funny, I'm used to doing this online. Is there a move to approve the minutes?
So moved.
Second.
All in favor?
Aye.
Any opposed? Thank you. Thanks, Ben. All right, so for Jen, what we're going to do, I put together a few slides, not a lot, just to walk through where we are with the strategic plan, the progress we've made so far, the things we're still working on, and then I'm hoping to have a conversation. This is not a meeting at which we're taking any votes or discussing any regulation, but just to have a conversation about overdose deaths and about gun violence. Ben, are you able to advance the slides? Or
Yes.
should I? Okay, thank you. If you're going to be over there, how about a chair?
Ben, here, how about you sit here? I can move.
But we can just, wait. Stay where you are.
Oh, okay.
You can't possibly squat for
Yeah, I
the
was
next
gonna say,
15 minutes.
your
I mean,
legs-
maybe you can, but you shouldn't.
Your legs will be asleep when it's time to work out.
So you all, I think, have seen this, but just walking through, these are the strategic priorities that we laid out in our 5-year strategic plan. Some are internal, some are external, but just walking through centering equity through everything we do. Improving workplace well-being, this is especially important after the last few years. Our staff still are pretty tired and burned out, and vacancies are still a problem across the department. We are using the Surgeon General's framework for workplace mental health and well-being. If you haven't had a chance to dig into that, I would really, really recommend it. I usually hate things like this. I mean, just honestly, this one's really good. We are focusing on strategies to ease administrative barriers. This is really my chief of staff's main job, is make it easier to get stuff done. Preparing for future public health emergencies. We certainly have it on our mind. We have experienced a lot these last few years, so trying to make sure we're ready. Improving the health of Philadelphia's children, ensuring access to primary care. I feel like I should say thank you to Scott. Using 7 is the catch-all, data-informed strategies for the major causes of early death and disability. So this is the everything else. And then achieving accreditation and public trust in the medical examiner's office. So if you can go to the next slide. So in terms of the equity work, our Chief Racial Equity Officer, who now has a team, which is really a huge advance, has been working on this health equity prospectus, getting input from internal and external health equity councils, and they've come up with 5 foundational components. So community engagement. One of the issues that we certainly see across the department is lots of divisions. There are 10 programmatic divisions. Most of them have a community engagement arm. So trying to put that together so we're more effective, less annoying, we can think through what our strategy is. Data equity, one of the things that we found was that we measure a lot of things. We were not disaggregating those things by race and ethnicity consistently. So just trying to think about where are the opportunities to do that. Workforce development, I just talked about. Communications, this is a huge piece, making sure that when we are communicating, we're reaching everybody. Thinking about multiple languages, thinking about ASL, thinking about people who don't use social media, like how are we getting info to people? And then public health ethics. This is one that has come up a lot in our discussions in different ways, even if we haven't labeled it that way. But if we're going to do something that has a coercive element to it, is it worth that loss in order to do the thing that we're trying to do for public health? Who decides? How do we make those decisions? So, next slide. So this is the Surgeon General's framework, just to show it to us as we're talking about this, thinking through all these different aspects. Mattering at work makes a big difference to people. It's the main reason our folks work for us, even though we don't pay as much as the private sector, and we often ask people to do completely unreasonable things. But that's sort of why they're here. We've heard a lot from our staff in staff surveys about the need for opportunities for growth and professional development. And Drexel, thank you Drexel, just finished a training needs assessment for us, which is going to help inform that process. I should say thank you to Drexel, to you too. Protection from harm is coming up more and more, unfortunately, especially in our sites that are out in neighborhoods with a lot of violence. So, I'm sure you're hearing about this from your staff as well. Connection and community, people want to know what's happening not just in their division but across the department, and so thinking about how we can build that. And then work-life harmony, meaning people can go home at night to their families and on the weekends and so on and aren't working all the time. Next slide.
Just a quick comment on this. That, if you go back for a second, that his work on this assumed, I think, a non-hybrid workplace. I mean, you're talking as if it's a non-hybrid workplace, although some of it, because I've run into this a fair amount, right? We have some of these great models and prongs. I'm not saying they're wrong, but connection and community is sort of this, is a new, and where might that be? The local coffee store, the across cubicles in this,
Yeah.
So just to point that out, because HR departments, particularly in Philly, where significant percent is still not back or is not going to ever come back to that model, needs something.
Yeah.
I'm not saying not usable, but it's very interesting. It's centered on a worker voice and equity, and I always say, okay, where is it?
Yeah, I think it's because all of our staff are in person at least some of the time, and many of our staff are in person all of the time. So it's a little bit different for us. Our health center staff work in person throughout. Environmental health services and so on. But I think, the entirely remote section of time was really tough for them. And people tried to do different things to connect, but it just doesn't work that well.
No.
But for our staff, a lot of what we were hearing about was newsletters, town halls, like things to connect us. All right, so I talked about a bunch of this, but one of the things that we heard from staff in our staff survey, which we've now been doing every year for 2 years, is a wish for leaders and managers to get leadership training and management training. We tend to promote people, put them into positions, and sink or swim. And so, fortunately, we have this CDC grant for workforce development that includes money for leadership training. So we are able to, what we did was to research different programs around the country and then put together a kind of menu of choices. Staff can do things that are not on that menu, but we have had a bunch of people doing the Cornell Leadership Certificate. We've had a couple people doing the Columbia trainings. There's going to be more, but we're kind of having people pilot so we can see what they think of the trainings, and then we'll have subsequent waves of people. But I think it's interesting when people want someone else to go to training, but that's a real need. In the training needs assessment, there was a lot that I think is very useful in terms of onboarding training, thinking through some kind of an internal training academy as well. There's a lot of city processes that are the opposite of intuitive, and trying to make sure that people have ways of learning that. So that's a big piece of this. We did send, I think, 130 staff members to the Drexel Summer Institute. I think we may have some growing pains on that one, but our EPIs were ecstatic. We'll touch base and kind of figure out. I think we need more options than that, because I think there's some staff who want to go to trainings, but maybe an EPI summer class may not be the best fit. But it was a nice start to be able to offer that. We are now having regular full department town halls, sometimes during the day, sometimes at night, so people can come. A regular newsletter. We're restarting Public Health 101. We had one in-person session, and then we have a lot of people that need to get trained, so we're going to have a whole series of them starting up later this month, I think in 2 weeks. And then we have a whole bunch of things that are in the planning stage still that I think will be really important, but a mentorship program for staff, a pipeline internship program which is planned with Esperanza. We have very few Spanish-speaking bilingual staff, so working with them on that. This idea that I threw into the grant proposal and now have to make real, called the Public Health Academy, which I think will be an internal thing. It's modeled on something that the Department of Defense does, in which they bring their new staff, after their first couple months, they bring them together for, they do several weeks. I think we would do a week, but of in-depth training so people really understand what it means to work for the department, how things work. Not their first day, because they need to have their feet on the ground a little bit, but just to be able to learn more about what we do and why we do it. Lots more professional development opportunities through the grant. Opportunities to spend a day in another division. We have this interesting cultural thing, and I don't know if this exists in your institutions, but all of our folks seem to believe that their division is the most dedicated, the most real, does the best work, and that everyone else doesn't really get it. And it's, like on the one hand, I'm really glad they're proud of their divisions, and on the other hand, I don't know that that's the most productive thing ever. So
She's laughing, divisions, departments.
yeah, So, like, for someone to spend a day in somebody else's world seems useful, and also, there are connections between our divisions, so having more people who understand other divisions seems helpful. Also, I think it would be fun. We have a bunch of contract staff now because of the pandemic who we need to move into vacant civil service positions. So that sounds, I can say that in one sentence, and that's like years of work, but important. And then the good news that we, when we did the staff survey this year, almost everything had gotten better, at least a little bit. So, we're moving in the right direction, although we still have a lot of work to do.
What did you see as some of the issues when you said moved a little? Were there things that there wasn't movement, or things that you hoped they would move more but they didn't?
I hoped everything would move more. I think it's thrown off because there are some divisions that are much, much happier and some divisions that are less happy, where there are issues that we need to resolve. So that throws it off some. I thought communication's gotten significantly better, but it's still only around 60%. And I know our comms folks are, they're running these newsletters, they're doing town halls, they're really trying to get info out to people. I think there's still a lot of people we're not reaching. So we do have an internal comms person who will be coming on in the next few months, probably. I want to say weeks, but really months.
Realistically.
Your conversations with other health commissioners, is this pretty much the feel of major cities and public health?
It is. I felt bad because our vacancy rate has been in the 20% range. Chicago is close to half. So, yeah. Now, Chicago isn't allowed to give any remote time.
Any what?
Remote time. They are all in person all the time. And I think that's been tough. But, yeah, it's a struggle everywhere. It's interesting, though, because it's also, you probably all know this, lots of people are going off to do their MPH. There's a big upswing in people interested in public health, but the public health staff is exhausted, burned out, and going off to work in other places. So. All right, so easing administrative barriers. So there are some things that we're doing just to try to make connections, because that will save time and effort. Those, I mentioned community engagement. We now have an access and functional needs group, so really trying to focus in on people with disabilities and what we need to be doing across divisions. Our EPIs are now connected, and Megan Todd, who's our chief EPI now, has been working hard to kind of bring people together. And then our communications groups are now connected as well. So one of the real challenges of working with the city is the way we do anything to do with money is, unlike anybody else, we use software systems that are from, I believe, the 1980s. So when you come on, you have to learn that, and there's no handbook. There's all sorts of, at some point I want to sit down and have people make a list of the most ridiculous things that they know about working in city government, but anything to do with fiscal is just really hard. So we have managed to create a position of a training officer, because otherwise you come and you are now in charge of fiscal for a division, and good luck. You have to kind of call people and ask for help and try to figure it out, but there's no training system. So we're trying to fix that. And that's one of the biggest complaints we get from staff too, is how are we supposed to figure this out? We also now have a workforce director who's working across civil service and contract staff and really trying to fix all this, and she's fantastic. And then HCO staff are working to help support this. So, for example, if there's a division that doesn't have an account clerk, they can do the invoices and some of the accounting work in the meantime while they're hiring, just so they're not left with no help. Next slide. So, on to the outward basic stuff. So preparedness, I've gotten much more interested in preparedness in the last 2 years. There's a few things happening right now. One of them is that we are going to be having this interagency planning exercise with the Department of Homeland Services and a whole bunch of federal, state, and city agencies, October 17th. This is in response to a problem we identified in Philadelphia, that we have had 3 mass displaced person events in the last 2.5 years, 3 years. And we will have more. Guarantee you we will have more. And there's no particular plan for that, just on a national basis. Philly actually does this very, very well. But it does it very well because, people know people and they call so-and-so when they have a problem, and that's not a sustainable plan. So we are doing this giant exercise with lots and lots of people to try to create that plan for what would the medical response be to a mass displaced person event? What should it be? What should it be if that event has 1,000 people? What should it be if it has 10,000 people, 100,000 people? Because this is going to keep happening. We had 29,000 Afghans come through the Philadelphia airport. You'll probably know about that one. We had United for Ukraine, which we actually used as kind of a remote model, creating a way for people to call or use the internet to find out where to get services, but without providing a site. And then we've had the buses from the Texas border, which has its own interesting challenges. So anyway, so that event is happening. We're doing a tabletop exercise on medical countermeasures. So this is like if we had to give antibiotics to the whole city in 48 hours, some terrorist event or something for which we had to do that. We'll do that tabletop on October 25th. This will be the first, but we need to start doing these regularly so that we go through the motions of what we need to do and everybody knows the rules. The third one is my personal favorite because when I started, my first question was, well, one of my first questions, remember when PES blew up and there was a risk of hydrofluoric acid blowing up, and there was a decision made quickly that we didn't need to evacuate. And as the person who would have been in that role to make that call, I thought, I have no idea how they knew that. How did they know that? And I started trying to find the answer to that question, and I couldn't. We did have lots of documents about various kinds of emergencies, each of which was more than 200 pages long. So anyway, we now have a library of executive summaries between 5 and 10 pages each about a whole variety of emergencies. And I have it printed out in a binder in my office, and we have it online, and we're going to bury it in lots of places. But just something somebody can look at fast in an emergency. And the longer documents are still being built out in terms of updating everything. But I don't think 224 pages is going to help us if something happens. We've also built out public health communications so that if something hits, this is why if you have to see there's a junkyard fire, for example, the health department can now respond to the public within an hour. And we can do that because we already have the communications built. So all they do is sub in the location and getting those translated in advance so we can get those out. So it was sort of the realization that most emergencies, like you can categorize emergencies. If it's an air quality emergency or if it's, there's a whole variety of them, but just trying to build the communications so they're ready to go rather than something happens and we have to sit down and write it.
That's it. Yeah, as you go. So with that, communications, preparedness, across the city, there are multiple touch points. Let me back it up. So places like city governments I'm of course always thinking like a university person, but they use Koali or Rave. These are software programs, platforms, anything, so that should the commissioners change, we have a change of the guard coming here, so should anyone change, what you are using is what police and fire are using, I know, but
Yeah.
people, the switch stays the same. The work is the same. Whenever I hear written document on a shelf, always good. I know what you mean.
Oh.
You said it's also in the cloud somewhere.
Yeah,
So
I
are
just
you-
printed it to have it
Yeah,
easy
no, I
to
got
find,
it.
but
So
yeah.
did the health department or the mayor purchase software across the whole government that everybody has their emergency plans, or is this specific to the health department?
So the Office of Emergency Management
Right.
runs the systems that push the stuff out.
Yep.
But we create it and then we pass it to them.
So that'll stay in whatever system
Yeah.
our city's using, and that'll be the same for others that have to get on this, because there'll be other kinds of emergencies, not necessarily in the health umbrella.
Yeah, but emergency communications go through OEM, and they have that network, and they're constantly trying to
Okay.
enlarge it.
I'm reminding all of us about this, just because again, when the guards,
Oh,
whatever
yeah.
the guards are that change,
Yeah,
we're heading towards some form of a transition.
Right.
So,
yeah. But that's why I want things in multiple places, just in case something goes wrong.
yep.
The Public Health Lab, we've been trying to make this happen for years. Knock on plastic. They're actually moving to their new state-of-the-art facility in less than 2 weeks. The building they're in is ancient. The walls ooze orange goo. There are machines in there that we cannot identify. They need to move, and they are moving. It's been interesting. Things that are still in process, we're creating an emergency response corps internally of people who will have some extra training in terms of responding to whatever happens. Our preparedness team has been that team, but we need more bodies. And then the AFN work group, the Access and Functional Needs work group, is still working on a plan for people with disabilities in a variety of emergencies. Although there are pieces of that written into the existing plans, but just to have something larger. Environmental and children's health strategies. So we pulled the data on this recently. There are things that are still in process and things that are exciting. So I'm going to start with the exciting thing, which is that in 2019, City Council passed the lead-cert law. So this requires any rental unit in Philadelphia to be lead-free or lead-safe. It was to be implemented starting in 2020 and gradually as licenses come due. So finished implementation in October of 2022. Lead levels are falling, down by about 40%. And the question I had was, okay, but are we screening? Because they could be down because we're just missing it. And so they just pulled the data for me. And if you look at the screening rate is down a little bit in older kids. But if you look at screening for kids under 3, it's flat. So it dipped in 2020, obviously, but it's flat. So it looks like we have a very large decrease in lead poisoning in Philadelphia, which is exciting.
Thing on that. So
Yeah.
I've been taking a look at that dashboard for personal reasons, and found, for example, that the disparities on that are disparities on screening huge.
Yeah.
Like only 60% of Hispanic children are being screened, as opposed to 90% of all of the others.
Yeah.
Is that my guess is that has to do with probably lack of regular PCP or something for those.
It may. Kids get more regular care than adults, but Latino kids are more likely to be uninsured, although not at that high a rate. So one of the things we've been trying to do is to promote screening.
I fear that especially with the lower northeast, maybe I don't know the age of the houses there, but I know there's a huge growth of Latino
Yeah.
population there.
Yeah. The interesting thing is we're at a point now where every legal rental should be lead-free or lead-safe, but of course, so the implementation goes on. If we pick up an illegal rental, if we pick up a kid with a high lead who is living in a rental unit, it gives it, but still to have a proactive law that we're not just going in after the fact and the kids had the lead level is high, now we're trying to remediate, we're actually able to say this place has to be lead safe.
And if a kid tests above 3.5, which is now the threshold, there is something
Yeah.
happening.
So
But-
this is the big thing that's happening this fiscal year. So this 26% of home services, kids getting home services, is our baseline. In the fiscal 24 budget, which started in July, we have money to expand the super clean teams. And there's a big grant from HUD to do remediation. So the idea, for years, the department has only done home services for kids with a lead level of 10 or above, which anybody who does pediatrics or just has a child and has gone through this or, knows lead, like, it doesn't make sense, because if they can have a lead level of 10 or of 9, then they can have a lead level of 15 or 20. There's lead in the house, there's an exposure, if their siblings could be exposed. So we got, it wasn't that much money. That's the thing when we did the analysis. I mean, it's money, but dropping the level of intervention to the level that's considered abnormal, it just makes sense. So that was one of the things that we were able to invest in with this year's budget. So the goal is to get the 26% up to 75%. We're never going to get into every house because parents won't necessarily want us there, but just trying to make sure we're there, we're offering services. And there's also assistance with remediation, which is really important because it's expensive. Anyway, so all of that is exciting work to be done. The air toxics reg we talked about at a meeting a while back. This is AMR 6. This is the regulation of hazardous air pollutants or cancer-causing air pollutants. That passed in April. There's a lot of implementation work that's going on right now. And that's one of those things, as new applications come in for Title V permits, that'll have more impact as permits come up for renewal. So hopefully will help to make our air cleaner and safer. We had our first meeting of our asthma strategy advisory group. We've never really had a citywide asthma plan. And we had this great meeting at which people were so jazzed that when I asked them if they would, we did I think an hour and a half. I asked them if they would come to a half-day retreat in person to keep going, and they all said yes. But there's a lot we need to do. There's a lot of really smart people in Philly working on asthma, so including Tyra.
Mm-hmm.
So I think there's a lot that can come out of that group in terms of what we can do together on a broad range of interventions for asthma. And then the other thing like that, which is related to the asthma work and will probably get linked to it, is just thinking about how we address tobacco. I've said during pregnancy and the first year postpartum, but really I mean at delivery and postpartum, that moment when pregnant people often quit smoking, and then they go home and they're tired and they're stressed and think they start again. So thinking about what we could do at the moment of delivery before people go home, and then in the first year postpartum, protects the baby, protects the mom, and prevents really the intergenerational transfer of smoking. So all of that. Okay.
With the tobacco, does that extend to vaping?
Yeah.
There is, okay.
Yeah. There's less vaping in Philly than other places because vaping's a little pricier.
Yeah.
But yeah. Primary care access, about the 2 new city health centers. There is pushback on the Friends Hospital campus site. That's
Can you
another
say more?
There's a group that appealed the historical commission's approval. I don't want to derail us tonight, but
That's fine.
yeah, maybe another conversation, but yes. But anyway, we have funding to open 2 new city health centers that are desperately needed. They'll make a huge difference between them. They'll see about 46,000 people per year, and full spectrum primary care. We've also been able to do a lot of repairs and renovations. Some of you know, Scott knows, that I got to see Marin de los Santos, which has this really great lunchroom for their staff. And staff at the health centers work incredibly hard. And as we were coming out of the pandemic, I was at Scott's Place for a press conference on something or other and saw that and was like, this is what we need to do. So we were able to do some renovations to the health centers, mostly not in the staff areas, mostly in the patient areas, but they do include lunchrooms for staff, which hopefully will help a little tiny bit with retention, and just like taking care of people who take care of people. But there's a lot of just neglected maintenance that we haven't been able to afford that we did this past year and are trying to roll over funds to continue doing this year. Health Center 5 should not have sewage when it rains, and it does, or at least it did. So, for example. And the Primary Care Finder, and if you haven't looked at the Primary Care Finder, it's phila.gov/primary care. It helps people find free and affordable health care. And it has a filter so you can look for a sports physical or a pediatric visit or a chronic care visit or whatever it is you need. So this is just the why we need the 2 additional health centers. That lonely teal dot in the northeast is Health Center 10. There is this is a slightly old map, there's a little Spectrum site that opened up there, but it's like 2,000 or 3,000 patients a year. Next slide. And this is the Primary Care Finder. It looks just like the COVID Test Finder, which is the platform it was built on. And in the upper right is the tab you can use for other languages as well. As I said, number 7 on the strategic plan is the everything else. So I want to come back to gun violence and overdose deaths, but the biggest thing happening with our gun violence program right now is that Ruth Abaya, who is just amazing, took a national job that will let her work remotely, that will eventually let her and her family be in France. It's great for her, it's great for the nation, it's not so good for us because she was great. Pilar Ocampo is acting as interim, which is really fabulous. But we are still looking for a long-term lead for that program. In the meantime, we're going back through, so we had started a homicide death review, and we're trying to go back through all the recommendations that came out of that and make sure they've been addressed and kind of put together a public report on that. And continuing so we have this collaborative of the hospital-based violence interruption programs, putting together data now from that. Gun violence deaths, as you may know, are down in the city about 18%, but down from awful to just below awful. So that's just a huge area where we need to do more. Overdose deaths, you all have seen this data before, but we continue to see in the 2022 data that just got released a rise in stimulant-associated deaths, which are now 70% of overdose deaths, or at least what we're calling overdose deaths. There's usually an opioid involved, which is probably what's causing the death, but 70% of people have a stimulant, typically in Philadelphia, cocaine. I was just at a convening in New York City on this, and in most other cities it seems to be meth, but everybody is seeing a similar pattern. It's also increasing overdose deaths, especially in Black Philadelphians, and also increasing in older populations. So it's 45 to 54, 55 to 64, even over 65, those numbers going up. One of the things that came out of that New York City convening was the fact that we are all defining overdose deaths. Ooh, this is a new slide. Well, maybe. We're all defining overdose deaths differently. So, for example, Austin tests everybody. Philly tests, if somebody comes into the MEO, they get tested. Other cities aren't necessarily testing unless they have a reason they think it's an overdose death, which is going to just give us all different numbers. And then there's the question of, is there a level at which we call it an overdose death, or is it anybody who has drugs on board, which is going to throw us off in lots of, so we're all talking in different numbers. So if there's anybody at your institutions interested in that conversation, I think it's going to be really important, not just here, but nationally.
Where's the federal leadership on this?
I talked to the regional director of HHS this morning and suggested that we need to have that conversation, but nowhere yet. I don't think it's come up.
Not that
And we've expanded our bereavement team, which it's nice, but it's also an intervention. It turns out that a lot of people who overdose had somebody they loved who overdosed within a month or so. So, you know, we call these things accidental overdose deaths, and I think we're misnaming in lots of different ways. But that team has been really well received. Chronic conditions, just to name a couple of things. I mentioned the tobacco work, but the department's been working on water as a human right and working across city departments to try to improve access to water, meaning to try to prevent water shutoffs. And the city has come a really long way in the last couple of years on that.
Have you seen any fallout from the spill, the chemical spill, in terms of trust, people's trust?
I mean, lots of people, not necessarily in the health department, because, you know, water department event, but lots of people very frustrated by that. It's very interesting. I mean, that's a whole other conversation of when should we or should we not tell people things. That was a potential teratogenic significant spill. And there was lots of pushback against telling people. Had we not told people, I'm not sure that would have been a better choice. So, really interesting. Yeah. Maternal mortality, a couple things at Philly Joy Bank I hope you have all heard about. It's almost fully funded now. There's a couple philanthropic organizations that are hopefully about to donate, and we'll get it over the edge. We have a doula program for pregnant people with substance use disorder, and we're able to put some money into expanding that because it has a waiting list, which it should not. And then we're working on a universal home visiting program for all infants delivered at Einstein, then hoping to expand that citywide. And then ending the HIV epidemic. A big piece of this is making sure people have access to testing, so trying to have low barrier testing, active testing in pharmacies, a program that will mail tests to people. By the way, I was just hearing about a program at CHOP that will mail NRT to people for free, which is interesting.
Before you leave, are we going to, was there more discussion about overdose tests?
Yes, I wanted to
Okay,
run through
okay,
these and then
right.
for us to discuss. I think that's it. So if you want to put that, I don't know if it helps us to have that up. Yeah, so that's the sort of where we are. I mean, I'm happy to answer any questions, but I think for both gun violence and overdose deaths, where we are is not a good place. And we're doing lots of things. One of the things we learned from the New York convening is Philly's way ahead, yay, except overdose deaths are up, so not yay. I think that on overdose deaths, we need to do a bunch of rapid cycle. If I say PDSA cycles, does that mean anything to this group? Do you do because you're a health center person? Okay. PDSA is Plan, Do, Study, Act. It's rapid cycle quality improvement. So you basically throw something at the wall and you try to figure out if it worked. And if it worked, you scale it up, maybe you do something more formal in terms of evaluation, but you don't do like a formal 2-year study of the thing before you figure out if you think the thing works.
It's a good business model.
Yeah, I mean, I think it probably has lots of names in different places. In the FQHC world, it's called PDSA cycles. But just thinking about, could we look at, say, census tracts that have a high incidence of overdoses? Can we try something intensive there and scale it up? Because really on stimulant-associated deaths, we've got almost nothing right now. We're doing community education. I am not in any way sure that that's going to make a difference. And there's this story which I find incredibly applicable in public health of a man who is searching for something under a light. Do you know this story? I see one head nodding. Yeah. And somebody comes along and starts helping him search and then asks, do you remember where you dropped it? And he said, over there. But, I'm looking here because that's where the light is. And we do that all the time.
So this is very comprehensive and really very forward-looking plan. The one thing I suggest is, which we haven't done mostly in public health, is define what are the parameters of a healthy community. Because a lot of these factors are related to a healthy community. And then dividing the city into sections based upon historical, geographic, ethnic, demographic locations. And then try to measure all the parameters for that area globally, and then see whether the programs will have impact in creating healthy communities. Because this, whether it's crime, whether it's homelessness, whether it's poverty, access to health care, primary care, home care, you name it, it's all related to one concept, which is to create a healthy community. It's a different global vision for this, to put it all the pieces together. Because even this, when you talk about this, it's all related to what will be considered a healthy community. So it's form of an internal rating, and there may be inter and inter differences among the areas of the city that needs to be also studied.
Yeah, I mean, there is work like that that we do, and I think is done in schools of public health. You know, we look at Philadelphia. If you look at the Health of the City report, which is currently being revamped, but that's kind of what that's attempting to do, is look at the factors that lead to improved health as well as measures of.
That's for the whole city, and I'm
We
talking
do look
about
by neighborhood though.
Yeah.
areas.
Yeah, I mean, there is a data issue in terms of being able to get data by smaller smaller areas of the city. The PHMC Household Health Survey used to be the vehicle; it's no longer being done. BRFIS, the Behavioral Risk Factor Surveillance Survey, we pay to enrich that for Philadelphia, so to get a larger sample. But this past year, it's not clear that they could get a sample. Something went wrong. And it leaves us without a great surveillance tool. We've tried online surveys, but they're not representative.
So a lot of these factors, at least those here, there are multiple sources of data to
Sure,
extract the data.
yeah, for these,
Yes.
but not necessarily for some of the other kinds of metrics that we want to look at. But yeah, I mean, these, you know, certainly overdose deaths, there's enough overdose deaths that we can look by, we can hotspot those.
The health exchange for Pennsylvania could be used. These are real data, and you're familiar with it.
Yeah.
Real data of health records from any health institute, hospital that's participating and sharing the data could be used to extract data on certain zip codes, by zip codes, that later are aggregated for a whole area.
Yeah, I mean, so far it hasn't been that. I think maybe because it's mostly, at least in my experience of it, mostly billing related data, we haven't necessarily been able to use it in the way we had hoped. But I'm hoping as it develops more and it has more EMR level data, that maybe it will get more useful.
You mentioned earlier, going back to overdose deaths, and, you know, it was well over a year ago, maybe 2 years ago, we started noticing, particularly within the Black community, this increase fentanyl-based overdose that were, you know, and back to your PDSA cycles, you know, with the opioid situation, we had these concentrated neighborhoods and areas that we could see. It was very defined because of encampments or because of open-air drug sales or whatever. I know you know, there's been this target now that we've got data to support what we were seeing clinically, that yes, it's happening more in communities of color, and it's not necessarily around opioids, but we're seeing that fentanyl is mixed in with everything else, everything. The harm reduction strategies, I heard it being mentioned, but I don't know the specifics. I mean, we don't have a concentrated area. It is hard to do a PDSA because it's all over the place. We know the harm reduction interventions work, but we are concentrating it in one area. How do you shotgun it all over?
Yeah, I mean, we do now have people out in North Philly who are going into neighborhoods, talking to people, trying to give out fentanyl test strips, xylazine test strips, naloxone, teach people how to use that. I mean, you know, the next step is going to be door to door, and not asking people if they use drugs, just saying, "Can I give you this?"
I think, you know, I mean, obviously I'm always thinking of QHCs just because of our outreach and our safety net and already being in some of those areas. But I mean, I think we're at a point now where private doctors' offices, every place just needs to have that known and available and part of the discussion, because we don't have a concentrated area any longer. And we're talking about it infusing into more recreational drug use that has in some places become acceptable, and it needs to be reached to all areas. So
I guess this has come up, and I'm wondering if you have thoughts on this. I asked every patient I took care of, thousands of people, if they used cocaine, heroin, etc. I can count on the fingers of one hand the number of people who said yes. And I don't know if it's me, the way I was asking, or if it's the relationship, because, these are people you know and you take care of, and do they not want it? But, and the people who did tell me it's because something happened. Something happened because of their drug, like they had a positive drug screen, or, do you think that's generally a problem in primary care, or do you see people talking about it?
All of the above. I mean, having trained generations of students and residents, first you got to teach them how to ask. Did you drink alcohol? No.
Right.
You drink 20 beers a day, but I don't drink alcohol.
Sure.
So you don't ask
Yeah.
the right questions, you're not going to get the right answer.
Right.
And it's kind of the same thing in terms of drug use as well. So yes, you and I are trained to be very specific and rattle off to make sure that you're just not going to say drug use, because that means putting a needle in your arm. And I'm not a drug addict.
Right.
So I use cocaine every weekend, but I'm not a drug addict. So yes, asking the right questions the right way, and then even when you do that, it is part of that trust. I have found that the trust is there, but it takes a while to build it. And yes, people will tell you what they use, where they use it, how they get it. But that's me. I don't know that everybody has that ability
Yeah.
to be able to get that kind of information.
But I mean, if you think that it would be useful, I think we could get naloxone and fentanyl test strips and xylazine test strips to the FQHCs, and people could give them out. Do you think?
I think, my point is, I think it's more than the FQHCs. Yes,
Yeah.
we're safety net, yes, we're seeing large chunks, but because of, yes, my point is, the harm reduction has worked.
Mhm.
It needs to be ramped up.
Yes,
Yeah,
it needs to
it
be
needs to
ramped
be-
up, it needs to
yeah.
be disseminated widely. We kind of target it, we focus it to these neighborhoods and communities where we knew there was obvious problems, and I mean, when I say it worked, I mean, obviously, we still have a gigantic problem.
Right,
But
but
it's-
that's what
it's helping.
Agreed.
It's
Yeah,
helping.
and that's kind of where we got to about a year ago, and that's why we started this North Philly effort, which, needs to be scaled, but yeah, because we clearly can't just be in Kensington.
What do you think, Cheryl, to your point about asking, right? So you may ask Scott and he may say no, but if you're distributing test strips and Scott knows I'm using,
Right.
and there's an opportunity to get it out that you might not see me as a patient, I still think there's an opportunity,
Yeah.
what you said in terms of the shotgun approach.
Yeah.
If the opportunity is there to get it out and it's not the direct user, but it's going to get into the hands and it's going to save the lives of
Right.
somebody who isn't presenting as a patient.
Yeah. So maybe the question isn't do you use, but can I give you this?
Yes,
Yeah,
yeah.
and even pharmacies, I was thinking. too.
Pharmacies, I mean, I know that there is the discussion, barber shops and beauty salons and all of that, and that's fine and good as well. But in terms of healthcare facilities, there are still lots of private practices as well as university-based practices. Temple's practices, Drexel's practice, everybody has their own their university practices as well, and they're not FQHCs, but they're serving sometimes some of the same communities, and they often get lost in that or forgotten in these conversations. It always seems to be the Philadelphia Health Departments and the FQHCs, but there's more out there that's taking care of some of the same patients, so. Same communities.
Just to add to that, it's also not always about the person who's using. I mean, frankly, grandma wants to
Absolutely.
grab some of those.
Yeah.
Lessons from HIV was, and continues to be, but mainly was as soon as there was treatment, every grandparent who now was left raising kids who were using dragged those kids in by their ear, literally, to get antiretroviral therapy, because given the choice, we want our loved ones to be alive, in most cases. So I can see, I might grab some and say, you know what? I want to have this conversation with someone I've been thinking about, and it would be great to have that conversation and hand that over. Now I'm in a different place, but there are other people who would like to know that. I did, if I can, want to say a couple more quick things. I'm going to be quick and just say, maybe we were headed this way anyway. I remember about the overdose deaths and where we were. I was trying to remember 2019, where were we? But a lot of it, this slide and a couple of others, is this profound thing that happened to all of us in this inner city that showered down on the context of inequity and problems to begin with, And then, for better or worse, you know, we had a lot of inadvertent fallout from federal policy, a lot of things. Some people believe some of those policies created the money to buy the guns. I mean, we can go
Yeah.
in this spin, and I say this, all I keep thinking about it, how is, you're all gonna think I'm nuts. You know what, just a handful of weeks ago, you could pretty much go to any Phillies game you wanted to. There was a seat wherever you wanted. You could get a ticket. You know what, you didn't even we would get a ticket and just walk through the alley and get some food and whatever. Now, you gotta know somebody, you gotta be in the lottery, you gotta hope. The place is full of hope. What's his face dubbed this as collective effervescence. All of these things, I'm not saying it's the panacea, but there doesn't seem to be this overarching, not your thing, context of lifting and communication. So that we're left chasing each thing that are crossing populations. And if I lost anybody, I'm bringing up the Phillies specifically because the collective effervescence now of 45,000 people all screaming and feeling united with strangers is vastly different than just a few weeks ago, when you could have picked your seat anywhere. So, you know, it made me think about our sport teams, which a couple of them are actually pretty mighty, and what their role is, if anything, and whether those are the right leaders anyway for this population. I don't know. But I will say, just even as I ran into Scott downstairs, I know we're in a public meeting, but just taking the train in today, which I've been taking the train a lot, but for some reason today when I took it in and took it all the way here, by the time I got here, I was pretty exhausted from the person who was ushered off the train, from some things that happened that were pretty like nerve-wracking, from the number of armed people I saw here, there, and everywhere. I mean, it was just so, to me, that context makes us less able to care across the city for these populations and gives us a city council that says no to some of the biggest potential life-saving maneuvers, at least one anyway that I can think of, that we need. So, I don't know if that's a Merrill issue, and I don't feel like I'm grandstanding, and I hope you're not hearing it that way. We are missing glue for people to be able to follow these great interventions that we're thinking about.
Yeah, I mean, there's no doubt, because, you know, the thing that's not on this slide, because it's not in our strategic plan, because it's not the health department leading, but, you know, poverty, racism,
Well,
educational inequity, like, that's the
It's
context.
emergence from a pandemic, though, that is specific, is what I'm
It's all
saying.
of those things, yeah.
I've been thinking, because in a way, you know, the trends of gun violence, yes, Phillies high. All cities have been following a similar trend, same with overdoses. And at the end of the day, it's all the same thing, poverty and inequality. And do you think it's addressing that may not be within the scope of PDPH, within a bigger scope at the city level? And I'm wondering if there is a role for PDPH in introducing the health conversation there. What I mean that is, for example, with to be clear, the banning of bettering of supervised injection sites, there is a health component there. There's life saved that could be saved. And I'm not 100% clear if that's in the political calculus there. If the amount of death and suffering that will be prevented with certain interventions versus the cost, versus the political cost, etc. And I'm wondering if there is a role for PDPH in introducing health in that conversation, in saying when we do X, it's not just about what costs here, it's not about that job, it's that job down the line will lead to 3 fewer gun violent deaths over the next 3 years, or those kind of things.
This is what we do. Much of it happens behind the scenes.
Yep.
But, you know, for example, if you look at our dashboard, the reason we put unemployment next to
Yep.
deaths is
Okay.
to make that point.
Yep.
There definitely is a role for the department in all of this. Certainly, you know, the overdose death conversations, talking with policymakers, but just sort of the where is there a place where we can intervene in this larger? You know, this is the water conversation, for example.
Yep.
We cut people's water off; they can't eat healthy food.
Right,
They
they
can't
become
wash their hands.
hopeless, and then,
Yeah.
boom.
But then that happens in conversations behind the scenes,
Yeah.
trying to figure out, how do we get there? It's an interesting thing when we have advocates come into the health department, because, we're government. So we don't advocate by marching around with a sign or making public speeches. We advocate internally. We try to come up with data-driven arguments and suggestions for solutions. Sometimes it works. When it works, it's very exciting.
So are there any, sorry.
I was gonna say, I have a question, but Anna, I know you were waiting.
Yeah, are there any, I mean, this is, I agree with all of this, but practically speaking, are there any insights that can be obtained by looking, in more detail, maybe you already have, in terms of who is it that's dying more? I mean, aside from saying it's among, Black Philadelphians, is it young people, is it people who are just using, who are starting to use, or is it, can we learn anything from, because it is a remarkable increase.
Yeah.
I know all these other issues have been ongoing
Yeah.
for a long time, so something else is going on perhaps.
Yes. So there's a group called OD-STAT. We do, in the same way that we do a homicide death review, we do a OD death review. And the idea is, if you do a deep dive, you can't do the deep dive into every death, but trying to do a deep dive into a sample of who's dying to try to understand that. And then the stats. So the overdose death report just came out, the chart came out Monday, that goes into detail in terms of the demographic breakdown, the geographic breakdown, and so on. But the death reviews are really eye-opening in terms of just what is happening. And one of the things that we see is people who, this isn't uniform, but people whose families didn't know they were using, which to me suggests that they probably weren't using daily. I mean, not that you couldn't miss that entirely, but just, it's a lot easier to miss if the person is occasionally using something. The New York convening included law enforcement, which made for some interesting conversations, but they think it's the drug supply. And what they said is that 50% of the cocaine that's coming over the border has fentanyl in it, which speaks to a question we've been trying to figure out how you answer, which is, what is the intent of the person who overdoses on a mix of cocaine and fentanyl? Did they know they were taking fentanyl? And it's an unanswerable question so far. And we've talked to a lot of people. We talked to some anthropologists who were extremely happy to be consulted, but not helpful. But, and trying to use demographics to understand that, but the problem is the person's dead and you can't ask them. And so, we do a survey of people who use drugs in the community, but that tells us what people who are alive and using drugs want to take. It doesn't tell us about the person who overdosed. That's exactly the thing we're trying to do, is to understand it better. But the DEA folks, they think it's the supply is both contaminated and much stronger. And pressed pills, which is a lot of what people seem to take recreationally. I say this as if I understand it. Don't think that I do, but 70% of them have a lethal dose of fentanyl.
Yeah, we've seen this before in a different form. I can remember going back into the early 90s when people were smoking marijuana and didn't know people started mixing cocaine, because cocaine was the problem. And I remember my training and what I was seeing clinically at the time. I was seeing women going to premature labor.
Yes.
Get all these young
Delivering on the
ladies
floor,
going
right?
into premature
Yeah.
labor. You do a drug screening on them, and they're killing cocaine, and they're swearing up and down that they'd never touched cocaine. Yes, some of them reluctantly admitted they were smoking marijuana during pregnancy. And that's when we started realizing that people are putting cocaine in the marijuana. Now, this many years later, we've got another kind of tainted drug supply where people don't know that the fentanyl is in them. So it is recreational drug use. And yes, it may be concentrated right now in the black community just because of maybe the drug of choice, but this isn't necessarily a black community issue. This is a population issue.
It's a population
yes.
issue, yeah.
So-
Can you say more? You said, being in New York, that Philly was ahead in terms
Yeah.
of what we're doing, but then there's the disconnect in terms of what we're seeing with what we're seeing in terms of overdose deaths. How are we ahead?
We're ahead in the sense that we've at least been trying to take on the stimulant issue, which isn't happening other places. We have a bereavement program that's been up and running for a couple years. It's being piloted in other places. So, you know, some of the ways that we're giving out naloxone and test strips and so on. So that's great, but as long as overdoses are still rising, you know, it doesn't.
Is there capacity to like the places that we're talking about, is there capacity to be able to distribute that many more fentanyl strips?
There's a big initiative that's about to kick off that will be door to door. And I think, and will not involve asking if people use. It's just what we've been talking about, you know, can I share this with you?
You said, and I maybe should know this, you said it's not working because overdoses are going up. Are they going up more than they are in other places? Do we know that?
It's very place dependent,
Yeah.
but we went up more in 22 than we went up in 21. And, you know, honestly, like, even if we weren't, they're still going up.
Yeah, but
I mean, New York City had this
the
whole
major
thing.
forces.
New York City had this whole thing they were saying about, like, well, the rate of increase is lower. I mean,
Yeah. But the problem is I see that if it's, and I think there's plenty of evidence showing that the supply side is super important in this.
yeah,
And the supply side is something that is much bigger than filling.
yeah.
It's a national
yeah,
level thing.
Absolutely.
So if there is a force driving a national increase,
Yeah.
but fills increases not as much as that, then something that is being done is working. So
Yeah,
how
that-
do we evaluate that?
So that's what I thought last year, because we were kind of flattening, but
Mhm.
we,
Yeah.
you know, we're up, I think about 11% a year. It just, yeah.
And going back to what Alma said about, and forgive me if I missed it, targeting communities, what data we have, you know, overlay with the mental health issues, since you even intimated, you know, some people are either using because someone else did, or using knowing they're going to OD to be with some of these are suicides in accidental. It's such a
Yeah.
tough one to know what is the intervention, who, but
Right.
also besides strips, what else we got?
Yeah, I
What
mean,
else?
bereavement counseling is an attempt at
Right.
that.
Which we should, I mean, these are great successes. We're going right for the,
But, yeah, you know, the other thing is if you take apart the demographic groups, and this is where the harm reduction approach has worked, but, you know, we used to have a problem that was primarily white Philadelphians using opioids, and that curve has been down. But the curve of black Philadelphians using a mix of stimulants and opioids continues to take off.
and so a little more, why? Why do we think that happened?
I mean-
don't want to presume to know.
The thought is that harm reduction approach, having people not use alone, getting naloxone available very widely among people who use opioids, like that is starting to, and you know, there is more bupe out there, there's more treatment available. So like that piece of it feels like it's making some progress, but we're still losing the race.
You know, I think public education as part of the harm reduction, because I don't think, again, that's why I wanted to use that cocaine and marijuana example, because they didn't know. And when they started to know, then people were being more careful. You know, I'll say stereotypically women out, you know, in bars drinking, they know about date rape drugs.
Right.
They know they want to watch their drink
Yeah.
being poured. I mean, education,
Yeah.
be able to make sure that people can take their own health. And I just don't know that the recreational drug use is going to continue and always has continued. And I just don't know that the education of what's happening with this fentanyl is out there. Yes, we can, one thing to put the test strips and all those other things, just basic education. Do you know, if you
Yeah.
know this is happening, then you will
Right.
accept having these strips around to want to test your supply.
Yeah.
Right, and, you know, were our interventions designed more, forgive me, for white individuals and white communities, because that's where the numbers were, such that what we've got, not only isn't it reaching, but it's not necessarily the right design for black and brown people. I don't know the answer to that, but I have to ask it.
Yeah, I mean, that's the work that our Division of Substance Use Prevention and Harm Reduction is trying to do,
Yeah.
is figure that out.
Now, do we know that people don't know? To
There's so
Scott's
much,
point.
right, these are all the
That's-
things, that's what I meant
that's
about the
it, yeah.
PDSA cycles.
Yeah.
Do we know that they don't know? Do we know that knowing would change
Would change.
behavior?
Yeah.
But but it feels like we just need to
Right.
try
Yeah.
that, and then we have to check if it's doing anything. So what we were talking about after the New York conversation was taking the outreach we're doing in North Philly, narrowing the geographic area, and then trying to see if we can measure a difference. Because I think it's, right now, it's, they're trying to hit North Philly, but, which makes sense in a world in which you're trying to address the whole city. But if the question is, does this work? It's hard to answer.
Do we know about the intersection of gun violence
I was
and
just
drug
thinking,
use?
I was just thinking the
There
same
is.
thing,
Yeah.
yeah.
We don't know a lot. I mean, the data on why people get shot, the police data, much of it is labeled as an argument, but like, what's an argument? Is an argument a drug deal gone wrong? It's very fuzzy.
Well, and the reverse, in places where there's gun-related homicides, are you seeing, as you said, somebody using because of the pain of a loved one who was lost, are you seeing overdoses in that area following a homicide too?
I don't think we've looked at that. That's an interesting question.
Because I was thinking the flip of that. That is that, do you think about that bereavement, not in terms of overdose, but a prevention, because of the individual who was killed? Do you have people who are now using to deal with the pain of a loved one who was lost?
Yeah, I don't think we've I mean, this is where being siloed isn't a good thing, right?
Yeah.
One of many places. But we are working on a bereavement team for the homicide side. I don't know if we've looked at I have to ask the
I'd
team.
be curious to see.
Yeah, I mean, I'm asking, if we prevent more overdose with whatever the intervention is, we need we need more specific data, can we, or what would we need to be able to turn to the powers that be and say, this is how we will reduce gun violence? Because to make that jump a little bit, one avenue to reducing gun violence may carry more meaning and support for this work.
Yeah. It's a good question of all the different ways those data sets could
Yeah.
be looked at together. I will talk to our MPs. I've kept you all well past 7:30.
Good conversation.
Yeah, it's really
Very
helpful,
good.
thank you. If you think of other things, as you may, after you go home, let me know.
Can you say congratulations on a lot of this? I know we glom onto
The negative.
some of this that really needs work in the city, but under your leadership in the health department, considering all to begin with, at least getting a push from the government for new health centers, working on morale, these are mighty wins.
Yeah.
They're mighty wins in a bureaucratic system.
Thank you. The thing is, we're going to put together a data brief on the lead stuff. The lead stuff is not my win, it's city council's win. But if we're right and we drop lead poisoning in Philadelphia by about 40% in a couple of years, it's huge.
Huge.
So,
Look, some of the issues you're addressing, a lot of these things, they existed well before the pandemic, so.
Yeah,
you know,
yeah.
You're addressing post-pandemic,
It's-
stop saying
it's good.
post-pandemic.
But,
Peak of the pandemic, you're addressing those issues, but you're also addressing issues that were happening even before that. So again, I agree with Marla, congratulations to a lot of things that you're doing.
Thank you all. You've been an incredible team.
Thank you very much.
Time
Thank
now.
you.
I'm hoping that by having us on a quarterly schedule, we can actually have a schedule. If you can make sure that the meetings are actually on your schedule. I'll ask Maya to send maybe just a plain
Send
email
it.
with the dates.
So that we can just
Yeah, with the
double check.
exception, it just populates the.
Well, she sends the Outlook invitation, but it seems like there's some kind of firewall issue with those, so they don't always come.
Yeah, the last one we didn't have.
Oh, I'm so sorry. Yes, I'm officially closing the meeting. Thank you all for being here. Thank you, Ben, for reminding me.
7:50.
7:50
Thank you.
p.m.
Thank you.
Thank you all very much.
You can all keep talking.
Take some, you can